Hey, my clock says it's 4:32, so we will call the meeting to order. Jennifer, would you call the roll, please?
Rubin.
Here.
Marcus.
Here.
Roloff. Lincoln.
Here.
Kenneth.
Here.
Moon.
Here.
Valerito.
Here.
Mason.
Here. Would all the board members touch your microphone, make sure that's on? Yeah. Okay, you need to make sure that on your mic, there's a little button there that needs to be slid toward you. Just want to make sure that everybody can hear us.
Hello. I guess it's not.
Okay. I think we're good. Yeah.
Green light.
All right. All right. Review and approval of the meeting minutes from September 6th, 2022. Would entertain a motion for those to be approved.
Make the motion to approve the minutes as presented.
For a second.
Second.
Seconded by Charlie McInnes. Motion was made by Rob Valerito. I think we can do a voice vote on this one. All in favor, say aye.
Aye.
Any opposed? Hearing none, those meeting minutes are approved. Review and approval of today's agenda.
Got somebody requested if we could move the second public comment ahead of the closed session in case somebody is moved to speak the second time, rather than having to wait for the closed session. I couldn't think of a reason not to, and I'm just gonna see what everybody else thinks. Otherwise.
Okay, so it's been suggested that we move item number 11 from today's agenda before the closed session, which is item number 9. What's the board's preference?
It's actually item 12, but that's okay.
No, it's 11.
No,
It's 11.
item
Yeah.
number 11 is public comment.
Oh.
Item number 12 is commissioners up.
I got you now.
Yeah.
Okay. Is there any, does anybody?
Page order I can't find.
It's
yeah, there's
it's
second page.
behind, it's behind the meeting minutes from September 6th, the page number 2 of your agenda. Is there any opposition to moving that public comment before the closed session? All right.
Then I'll move that we approve the agenda as presented, with the exception that public comment item 11 be moved to prior to item 9.
Okay.
That's my motion.
Part moved by Commissioner McInnes, supported by Commissioner Rubin. All in favor, say aye.
Aye.
Any opposed? Okay, very good. Which leads us to item number 5, which is public comment. The public comment rules are posted as part of our agenda, so I'm not going to go through and read them all again. Is there anyone from the public who would like to address the Board of Health? Thank you, sir. I have Mary Moore. Mr. Valerito, do you want to do the timing?
I will.
Ms. Moore, if you would come to the lectern and state your name and residence, and I believe you have 3 minutes. Is that one on, Mary, that microphone? Oh.
Somebody told me to point this at your nose, if that's good.
Yep.
Is it on? For me, it's a big target. All right. All right, good afternoon. Good to see everybody. I'm just going to get right to it as far as the main thing I want to say and what struck me about reading through the packet before this meeting. And then I've got a few minor sort of housekeeping things I want to say. Hopefully I'll get to them within the 3 minutes. The accreditation memo by Mr. Thorell especially struck me that we're being accredited, I guess, on a yearly or or a couple year basis. That was interesting to me. And I just want to say, like, I've been coming to these meetings for about a year now, to everybody's chagrin. And I've been kind of looking for some larger, what do I want to say, metric, if you will, to in terms of how is the health department doing? How, the stated mission, and this was in your memo, Mr. Thorell, which I totally appreciate, under the 10 essential public health services logo in the memo, sort of the mission, I think, of the public health was stated, and it's stated pretty well, to achieve optimal health for all, to protect and promote the health of all people in our 4 communities. And then one of the 10 essential public health services is specifically to assess and monitor population health. So my question for all of you is, and it's rhetorical at this point, theoretical, something to ponder, is, are we really doing the best job that we can with the $35 million budget of assessing, assessing and monitoring the public health in these 4 counties? Should we be looking more closely at life expectancy, healthy life expectancy, which are 2 different things I've learned, because the Chinese have surpassed us in healthy life expectancy, excess mortality in our 4 counties, disability claims in our 4 counties, and heart issues, I would suggest, in our 4 counties. There have been a lot of news stories lately, and I can't go into them because I only have 1 more minute, about myocarditis, pericarditis, blood clots, young people having strokes, etc. I heard a PSA in the 20 minutes that I listened to public radio recently about 16-year-olds having strokes. Clearly, there's a problem. Are we looking at that within our community? As far as my couple of housekeeping things, yeah, I would just want to say I spent my working life writing and researching and interviewing. And I want to say I appreciate what goes into these memos. So thank you, everybody that writes them. I want to suggest that you guys post the packet on the website before the meeting, a few days before the meeting, to be transparent to the public and help us. And then on the accreditation, I just want to say overall, let's be careful that accreditation isn't pushing us lockstep into behaving just like every other health department and not minding specifically what's going on with our people in our 4 counties. Thanks so much.
Thank you, Ms. Moore. Anyone else from the public that would like to address the Board of Health? Hearing none, we'll move to item number 6, RFP for legal counsel update. Mr. Thorell.
Yes, good afternoon, everybody. So we did receive from the RFP that was sent out, we received 2 proposals, one from Lisa Vogler and one from Plunkett and Cooney, as far as that goes. And just looking at the running down the differences based on the request for proposal that was sent out, the most glaring differences are the hourly rate. It was $250 for Lisa Vogler, and then Plunkett and Cooney was $200 an hour. The difference is Lisa's law firm, or not really a firm, but she's more of a sole proprietor, has a couple of counsel attorneys that help her out. Where Plunkett and Cooney at that $200 rate is more of a blended rate that includes basically anybody in the office that's doing work for them. So it could be a paralegal, it could be an attorney, it could be just anybody that's billing hours towards health department request. The charges, the difference in the charges are the way that they bill. Lisa Vogler is at a 0.2 minimum hourly rate, so like 12 minutes, versus a 0.1 minimum hourly rate, so 6 minutes for Plunkett and Cooney. She does not charge, Lisa does not charge for copies. Plunkett and Cooney is charging 25 cents a copy for black and white, 50 cents a copy for color copy, and then just both of them really charge other actual costs as they come up, if they have to mail something or whatever, as far as that goes. Billing is a little bit different. Lisa Vogler is bi-monthly, and Plunkett and Cooney is 30 days as far as like their billing schedule. And then travel costs, Lisa was time, no mileage, where Pumpkin and Cooney is charging time and mileage at 56 cents a mile. So just kind of running down, those are the major differences. Both packets were pretty complete with the biographies from the attorneys that would be involved, and the experience that they had. Obviously, we've worked with Jim Young for many years, so he has a lot of experience with Health Department Northwest. We've also worked with Laura Dinan at Pumpkin and Cooney for employment law issues for many years. So we have experience with both ends. So that's basically just the rundown of the differences there. Does anybody have any questions or from me?
Or, Mr. Marcus, go ahead.
I read over the packet too. I saw a lot of the same things you did as far as prices go. My experience with Plunkett at Antrim County has always been pretty good, to be honest with you. We have seldom had to convene to discuss issues arising from a settlement or anything that's going on, or something that we are not happy with their process or anything so forth. With that said, I believe there's a lot of value with the amount of people who are able to put eyes in front of on paper of an issue that we're dealing with at the county level, rather than maybe a smaller firm or even one person. So I see the value in why we're paying more to have that firm do it, because it's not just one person looking at it with one opinion, one view. You may have multiple people within that law firm putting eyes on something that might see something the one attorney didn't. So I actually understand that there's a cost concern, but I believe that Plunkett is a better overall decision to be made.
Actually, I think Plunkett and Cooney is a little cheaper.
You
More
got that?
inexpensive.
They're $200 an hour as compared to $250 an hour.
Well, once you add in the extra eyes with the billing process, and you start adding more people, there's more billing going on. So technically, it's a little bit higher. Technically.
Okay.
And I say that because if you're the lead law representative, and I am a clerk for you, and I have another associate, and all of us are putting 0.2 hours into it, I believe that one person who would have been doing that would have been less hours overall, rather than having 3 people do it, because you're working on multiple things. My job is to do this, your job is to do the same thing on one particular issue. It combines, therefore it does go up a little bit.
Okay. Any other comments from the board or questions for Mr. Thorell regarding these?
Sure. I just kind of want to paraphrase a parallel what Mr. Marcus was saying. Most of our county, the surrounding counties, do use Plunkett and Cooley. Otsego County does use Plunkett and Cooley occasionally. I think that there's an advantage to have a larger firm, more eyes, more resources, availability, less schedule conflicts, that type of thing. I think there will be an advantage. I think the price will be a wash. But I guess I would support a Plunkett and Cooney is what I would lean to.
Well, I noticed, well, let me go around the room first. Mr. Mason, this is, first of all, welcome to Henry Mason. He's our newest commissioner from Otsego County, taking Julie Power's spot. So thanks for being here. Welcome to the Shirley Roloff Center on behalf of Charlevoix County.
Thank you.
Do you have any input that you'd like to make on these proposals?
I'll pass.
Kind of throwing you under the bus for your first meeting. That's okay. They get better. Mr. Rubin.
Yeah, I guess I can't disagree with the first 2 comments that were made. If we have a legal issue and we have one attorney who's dealing with it, and he says, I'm not sure about this, but the guy in the office next door deals with this every day, and he can say, hey, take a look at this for 15 minutes. I think that's probably wise.
Okay. Mr. Coons. Okay. Mr. McInnes.
Emmett County recently went from an in-house to the council to a downstate law firm that has the broad experience that the three other commissioners have spoken of. And I think Lisa Vogler has done yeoman's work under difficult circumstances, but has done it well. And but I think that the opportunity to have scenarios exactly as Jared had said, and we're having it already in Emmett County using full scoper and Hoskin, so that one attorney does FOIA, another one does another area of specialty, and it's turning out to be a wise move because this is a complex world in which we live. And I think the fact that other counties have already had good experience with quantum tuning, and we're already working with one staff member, Laura Diamond, that you know, I'm
Okay. So I'm hearing a consensus. I guess what I would like is a motion to accept the RFP from Plunkett and Cooney. Mr. Thorell, before we do that.
Yeah, just can I say one thing before that? One thing I was not certain of, and it just might be just because I just don't know, is, you know, everybody's mentioned the work that they've done, like Otsego County or Antrim County or Emmett County. Is there any conflict of interest that would exist? You know, in the packet, there is nothing that is listed as a conflict of interest. There was a section in there that basically any potential conflict of interest, and you know, it said that it was reviewed and there was no conflict of interest. So, I mean, based on what they said, but I just wanted to bring that up just because they do work in some of the counties. So I want to take their word at it, but I just wanted to throw that out there.
I think in prior conversations that we've had, Plunkett and Cooney has done work for each of the 4 counties that are represented here, either at the county level or different municipalities within those counties. So that point is noted. But if they state that they have no conflict of interest at this time, then that's, you know, we have to take them at their word, I think, in their RFP.
Well, and it may be that they're a big enough firm where they can, you know, keep things separate under
Yes.
that umbrella.
Okay. Thanks, Dean.
Yep.
Then the question becomes, how exactly do we draft an agreement with what we do normally? It should be civil counsel. So I'm not sure.
I think the RFP
Spells it out.
is
Spelled it out.
is
Yeah.
the agreement, and what we would have probably once we take the vote, if we were to vote to adopt them as our civil counsel, then I assume that a contract would be coming from them that would be signed by either myself or
And Dan.
successor if we don't get it in before January.
There is a terms and conditions section of the RFP. So I think we would probably, if whoever is selected, I think we would maybe want them to affirm that those are adhered to.
All right, well, then I'll make a motion that the Board of Health retain Plunkett and Cooney as its civil counsel in accordance with the terms as laid out in the RFP.
Second.
The agreement to be finalized by staff and signed by you.
Okay. Moved by Mr. McInnes, seconded by Mr. Pallarito. Further discussion, Mr. Marcus.
Yeah, I'm glad you brought that up because I forgot about that portion. So the question that I had was regarding conflict. As far as I know, the only conflict that I was aware of and became part of was the conflict from the board versus a person within the department representation. So I wanted to make sure that that there's language in there deciphering, are they representing the board on a conflict that resolution regarding involving an employee, or are they representing everybody? That was my only thing I found was a little bit confusing, frustrating, and I believe majorly conflictual.
I think our RFP doesn't resolve that, because I think it says that the civil counsel represents both the board and the agency. If I'm not mistaken.
I think I read that too, but I wasn't sure. I was hoping maybe that with, if there was any type of language that kind of spelled that out better.
Yeah, I mean, the RFP does represent, you know, the health department as a whole and the board. I think a conflict with an employee, between an employee and the board, the employee would retain their own counsel, is the way I look at it, I guess.
That's what we thought too, right?
Right.
First go around. Okay.
Any further, Mr. Rubin?
Yeah, I'm good with the motion, and maybe it says it in the contract, but a lot of times when you hire a firm, there's a date when they start, and that wasn't stated in the motion. So I don't know if is it in the RFP, the date?
No, I think that would be in the contract that we come up with.
Maybe
so-
we don't need it, but I've seen it in the past where it specifically says, starting on this date, this is when.
I think if we were to pass a motion to accept the RFP from Plunkett and Cooney, there would be a contract that would come forward, and once it was signed by both parties, meaning by the board and by Plunkett and Cooney, I think we could ask that it be made effective immediately.
That's where
Would that resolve
that's
it?
where my mind was going, effective immediately
Yeah.
upon signing, but.
Sure.
That's fine.
Now, this, I don't think this is going to necessarily terminate any of the other relationships that we have with attorneys right now regarding current lawsuits or anything like that. But once we hire our civil counsel, we're going to need to lean on their expertise on how we go forward with all of the above.
I think it might be appropriate then that, assuming that the contract is signed prior to the next monthly meeting, that the minutes that the health officer invite a representative from Plunkett and Cooney to come to the next regular meeting to introduce him or herself and to permit this dialogue to go forward about.
Maybe who our point of contact is going to be, our regular point of contact.
Right.
Yeah.
Okay.
Okay.
Month.
Right, and it does spell that out in the RFP, who the regular contact would be. It would be Matthew Cross, I believe.
I saw that at the top.
The gentleman's name. And I just want to, you know, I think that's a great idea. And I just want to reiterate too, with the existing litigation we have going on, I don't think it would be wise to change horses in the middle of the stream, so to speak. Just because I think there would be we would spend a lot of money trying to get someone new up to speed.
Agreed. And I wasn't suggesting that we do make
Right.
a change. I just wanted to bring that to the board's attention as we consider this motion. Thank you. Mr. Marcus, you have
That's exactly what I was going to bring up. I want to make sure, because you know that they don't have to turn over some of their own inner office materials and time privilege stuff. So that would create
Right.
a major problem for us and it's so long. So it's better let them run it through.
I agree. Any further discussion or questions from the board? We have a motion from Mr. McGinnis to accept the RFP for Plunkett and Cooney. It's been seconded by Mr. Pallarito. One more time, any further questions or discussion from the board? Jennifer, can we have a roll call vote, please?
Mason,
Yes.
Valerito,
Yes.
Coon,
No.
Kenneth,
Yes.
Hinton,
Yes.
Marcus,
Yes.
Rubin.
Yes. Right, thank you,
Is our next meeting November 1?
Jennifer.
It's the first Tuesday, right?
That's the first Tuesday.
That would be the first, yeah.
Okay. Item number 7, MERS primary contact change, action required, Mr. Thorell.
Yes, I'm going to have Shannon explain that, just changing the MERS contact info for adding Mrs. Pulaski to the MERS contact.
Pretty much summed
That
it
pretty
up
much
right
summed
there. That's
Not much more to say.
The
Yeah.
MERS is the retirement program for our employees. So as the new CFAO, it would list me as the contact person instead of the previous person in my position, Terry Tallis. So we would change that, still keep our payroll person on it, still keep our HR person on it. And then also add Mr. Threll and Holly Campbell would also be added to it, our deputy health officer. We need a signature to go ahead and do that.
Kind of a housekeeping issue that we need to just change, put the appropriate contact people on board.
Correct.
Yeah.
Yes,
Okay.
sir.
Do we need a motion to do that, or is that, can we do that with consensus? In the green folder,
Green red.
Yeah, green, red, whatever.
right? I did look through this. Okay, so I'm gonna make a motion. The motion is to add Shannon Planowski. Forgive me if I didn't do
You
it
did
right.
it. Good job. Not easy.
Shannon Planowski, CAFO, as the MERS primary contact, and Daniel Thorell, health officer, and Holly Campbell, deputy health officer, as additional contacts.
Or
Moved by myself, supported by Mr. Rubing. Any further discussion? Hearing none, can we have a roll call vote?
Aiken,
Yes.
McKenna,
Yes.
Coon,
yes.
Valerito,
Yes.
Mason,
Yes.
Rubik,
Yes.
Marcus.
Yes.
Last page. Jen? Of the packet that you gave me? Okay. All right, give me just a second because I don't want to get too far behind here in my planning. There's that. Okay. Staff reports, Mr. Thoreau.
Yes, thank you. First of all, before I get going on my report, and we get into actually the staff highlight the Community Connections Program, I just wanted to again thank or welcome Commissioner Mason to the Board of Health, and actually also give this opportunity for the directors to introduce themselves and just kind of let him know, you know, what programs or what division of the health department that they oversee.
Keep it short. Josh tends to run on. I'm kidding.
Hi, I'm James Sunlander, Director of Regional.
Jeremy.
Thank you. All right. So right now I'd like to welcome Jen Balmer to give us a presentation on community connections.
I'm Jen Vollmer, and thank you for having me here today. Can y'all hear me okay?
Yes. Yes.
I am the Community Connections Coordinator for Antrim, Emmett, Otsego, and Charlevoix counties. I wanted to come today to explain to you what the Community Connections Program is, what we do, and some of the great things that we are able to provide for our community. Is it showing up on the There we go. Oh, wait, that'll be- Thank the Lord.
Thanks,
'cause
Ryan.
I would just sit here and say, I don't know what to do. Here is a little bit about our mission. So we are under the umbrella of the Shire. So our mission is to improve population health, increase health equity by reducing unnecessary medical costs through partnerships and system change. And our vision is healthy people in equitable communities, which includes a quote, universally accessible, comprehensive CHW navigation system. So I'll use the term CHW, that's a community health worker, and those are our employees who do the work that we do through Community Connections. So this is just, I think, a really cool slide that shows medical care is really only 10% of what makes an individual healthy. There are a whole lot of other circumstances that come into play, showing here their individual behavior, there's social, environmental exposures, all of those things. And those are the things that we see the person as a whole, and those are the areas that we try and fill the need to help a person become more healthy. We have expanded. I've been in this role for a year and a half now, and we had 21 counties. And because of its initial piloting days and stages, because of its success, quite honestly, we now have 31 counties and have added 2 additional health departments just recently that are getting up and running to accept referrals and be able to provide these support services for the members in our communities. So these down here more in the central Michigan area are the newer ones. So there's a whole lot of moving parts as to the Shire, the Community Health Innovation Region, if you all are familiar with that. And this just sort of is a fancy slide that someone other than myself figured out that talks about, again, the vision, healthy people in equitable communities, our network. There's a number of different people within our network. There's steering committee, there's the clinical linkages work group, there's the My Thrive work group, there's the learning community, and there's of course the residents and community partners that all work together, working towards the common goal of healthy people in our communities. We have multiple tools. There's the My Thrive, there's a Community Connections, of which I'm speaking to specifically, and then systems change. So the outcomes that we're looking for, again, health equity, you'll hear that a lot, obviously. The access, coordination of care for them into their resources as well, aligning our resources, all of that together to be able to help promote healthier individuals. Our Community Connections program, just kind of the basics of it, it's a free program, connecting adults, children, and families to community resources. There's no income base for this program, so it doesn't matter, how much you make, how little you make. If you have a need that we might be able to support you with, we will do our best to help find that for you. We address social determinants of health. So all those other factors that work into whether or not an individual is healthy, those are the things that we look at: food, housing, transportation, physical and mental health. There's multiple channels that we use, whether it's phone calls. It is a home visiting program, and so we do home visits where we can. We work to do like 85 to 90% home visits. So that's really important because there are oftentimes when you get into someone's home and you find they initially just were looking for help with, let's say, a roof repair. And then we find out, well, actually, they have a member in their home that needs a ramp. And so maybe we could help get them a ramp, or they're low on food. And so we could help them apply for food benefits. So there's lots of different things that can be gathered in a home visit as well. And by professionals, they're being cared for by professionals. We have nurses sometimes that will get involved because they often are involved in other areas in our health department and getting support there. Our community health workers, like I talked about, and social workers, or myself, I'm a licensed professional counselor, which is equivalent to a social worker. So these are different pathways. So we're an evidence-based program that we use to work through pathways. And basically they look through all of these different variables and see what needs to be done, what needs to be met in order to have this goal be met, have this need be met. And so we help someone find a medical home. We help them find employment, whether or not they need housing or health insurance. There's a number of social services areas that we can help. If they, just had a child and they don't have money for a crib, we can, see if we can get them a voucher to their local resale shops and find bedding or clothing. All of those are different pathways that we're able to sort of work through and have evidence-based model that we go through in order to meet their needs. The process is pretty simple. So there's a referral to our Community Connections program. It can be by an individual themselves. It can be through a referring doctor or clinic. It can be through a friend or family member, through the school, through our health department. Again, like I had mentioned previously, if they're working with another program that we have, if they recognize a need, they can refer to our Community Connections program. Our central intake registers the client, and then myself as the coordinator makes the initial phone call to the individual and kind of gets a feel for what it is that they need. So that way I can set it up for the community health worker, who then is going to call with hopefully a little bit of background information to say, hey, this is what I can offer you, you know, kind of educating themselves on the front end to be able to help lead them in the right direction right from the get-go after they make that connection. So again, they do a home visit, they work through the pathways, they identify the various needs that they might have, and then they confirm, that's how we close a pathway. They confirm that this connection to the resource has been made and in fact considered successful. So certainly we measure and document all of those results in our electronic medical records program that we have. And then we offer feedback to our referral. So they know, you know, so if somebody makes a referral a month or 2 months ago, hey, whatever happened with that, we have feedback with them to let them know sort of what happened. Here again is just the varying ways that you could take referrals. This is a great website. Our Shire website is really nice now that we have multiple health departments. You can go there and you find there's, you know, multiple rectangles right on the front, and it gives you all of the counties. So it would give our 4 counties under ours. You click on that button and you just have to answer a few questions regarding your need and your, you know, address and name and that type of thing. And then it will go to our central intake. Send via secure fax, secure email. Like I said, can just call and make a referral that way. Or we have web-based portal that we have MOUs with multiple doctors, offices, and clinics and hospitals in our region. That there's a confidentiality, release of information, all of that is all taken care of on the front end. And so then we can communicate back and forth with each other and share information based on this web portal and agreements that we're already taken care of. So this is just some kind of feedback from some of our clients. Listened to me when asked 100%. She was a great guidance counselor, helped me with probably some questions she's never heard before. It was like I was talking to a friend. Kept me up to date. One thing that was special is that she would come to my house and explain things to me and keep me informed on the progress of what we were doing. I was able to contact her by phone, text, and email. Really easy to get a hold of her in multiple ways, and that was really nice. So some people in the room have heard this presentation before, but one of my favorite things about, and the thing that I just really pride our program, is that our community health workers, they answer the phone and they call you back. And so in a world of, you know, sometimes resource poor areas and people with really heavy, big workloads, you know, people don't always get that. And so I think that that's a really great part of our program that I am proud of. The girls who do the work and really genuinely put in their care. And then here too, you know, 100% honesty, cared about me 98%. So those are some really good, I think, feedback points for our program. So another part of our community connections work is we work with managed healthcare plans. We have multiple contracts with a number of Medicaid different, I don't know, there's lots of different outreaches of, yes, health plans. It's like there's lots of different fingers to Medicaid. And so what we do is we make calls to try and, again, work towards having them lead a healthier life. And so the managed healthcare plans might send us a list of 100 people who have used the ED 6 times or more in the last 6 months. And that's a red flag, right? If you're using ED for that many times, maybe we need to look into why you're using ED that many times. And so through our community health workers outreach, we call and talk to them and they say, well, I don't have any insurance or I don't have a primary care doctor. Well, hey, we can talk with you through our community connections program. We can see if we can get you signed up for Medicaid. We can see who's accepting your insurance, and we can get you a primary care physician to avoid then the repeated visits to the ED or overall better general health so that it decreases inpatient visits. I don't have the number specifically, but I know that it was over 1 million number, James, specifically? Over 3 million okay. So over $3 million worth of savings that this type of work has provided for the managed healthcare plans. Because again, we're trying to get ahead of that, right? We're trying to be more not, reactive, but trying to be more preventative in some of that care and supporting our members in the community. There's an awesome website that we put data in quarterly that you can see here at northernmichiganshire.org. You can get to that website. And it talks about, this was when we only had our 3 health departments initially, and now that there's 6, but you can go to this website and it gives you, as you can see here, the total hub referrals for the first quarter of 2021, and then breaking it down to DHD 10s, Grand Traverse, and then ours at Northwest. It goes into how many we were able to successfully close, what were the reasons, that was it food, was it housing, what were the kind of outliers as far as where the need was, the age brackets. So all that information is there in case you're curious to go. It's pretty interesting as far as what the needs are and how they vary time to time. In the winter months, obviously utility help is, more of a need because of the colder months. And so it's interesting to read through that if you ever wanted to go there. And then this is our team. So I'm Jen Balmer, the coordinator in Charlevoix and Emmett. Our community health workers are Jody Mundy, Meg Smoot, Carrie Vignew, and then at Otsego and Antrim, our community health workers are Ashley Dominic and Christine or Chrissy Green. That concludes my spiel.
Thank you, Ms. Balmer. Does anybody have any questions for Jen?
Yeah, I guess just a comment about the 31 counties. In my opinion, that's too big. All 31 of those counties are unique. We have different needs. Antrim County, we're part of a 10-county consortium of our Commission on Aging. And of that, we have the second highest number of people that are over age 70. Almost half of the people in our county that are over the age of 60 are also over the age of 70. And I'm just bringing that up as an example. Looking roughly at that 31 counties, I'm guessing there could be 1 million people in there. That's almost the size of a congressional district. And to be specific and meet, Emmett County has their own needs. We all have our own needs, and sometimes we can get together and address common problems, but my gut feeling is it's too big. It's the bigger you get, the more cumbersome you get, and it proves to be less useful to eat everybody than if we split it down and made it a little more specific and a little more useful to specific counties.
Sure. Can I answer that question or
Yeah.
respond to that? So that our community connections program, like Jen shared, our team really is focused on the county because it's absolutely super hard. Like you don't know the resources in 31 counties, but those hubs, that's why they have hubs. So throughout the 31 counties, it's what she's demonstrating is the success of the program has almost gone statewide because of the success of the program. But our program is just our hub, which is the 4 counties. So it really is small so that we can make that impact in our communities and be experts in this area. We aren't experts in 31 counties. That's not the role of the Community Connections program. It really is just here, but the program is being replicated other places, just like the WIC program is replicated across the United States.
Okay. Mr. Marcus.
There's a little bit of experience I have in this area because the Northern Michigan Counties Association, the group of commissioners that represent those same counties, all meet together every month. And we've talked about this before. One of the benefits of this is every county has maybe a couple little NGOs that provide a service that another county doesn't. But if you could tap into those and go to one location phone number or one person, you're now leveraging those type of accesses. So I think it's beneficial. I think it's a little bit early to try to say that it won't work. I'll give you an example. We just in Antrim County recently adopted or signed an agreement to support. I believe it was either diapers or cribs. Maybe someone knows what it is, but a lady who started her own little crib thing for babies, and all they do is just give cribs away. I mean, how else would you get that if you didn't have access to it? Unless if you're in Alcona County and you find out Antrim's willing to give them to you, all you gotta do is ask. Sometimes that works out that way. So I see it as a great benefit, having one contact person, one phone number, touching into it, rather than having multiple phone numbers and no one know who's going where and who's talking to who. So I think it's a great thing.
Mr. Rubin.
The other comment I had was it talks a lot about equity. And when you talk about equity, the first thing that comes to my mind is equal. And I don't think that's where we want to go. I mean, I could pick on Dan and say he makes 3.5 times the amount that I make in a year, but I don't want his job either. And I don't want his headaches. So I'm happy that he gets paid extra to deal with that. I could bring everybody a cow here. I don't think everybody here wants a cow.
I would
Probably-
like one and I'd like it processed.
Yeah.
before-
So my preference would be, instead of using the word equity, my preference would be to improve their health. I want everybody to be healthier. I don't want everybody to be equal. We can't be equal. My genetics aren't the same as anybody else's genetics. My family situation is not the same. We're created different. We have different needs. We have different things that we need to address. So that's just a side note.
And I can talk about that too. Health equity compared to equality is actually two very different words for that exact reason. So we can share this in the future. And I think that Jane has shared it before, but it's really the idea of everyone having the same opportunity, so that whether you're, you use the example of yourself and Dan, you have the same opportunity to get the correct health care that you need to get. Make sure you have a primary care provider to feed your family the same amount. So if the visual is looking at a baseball game and you have 3 different height people, and equality would mean everybody gets the same size box, right? So your short people really still can't see over the fence and be able to watch that baseball game. But equity is this kiddo needs a box that's this tall and this other one needs a box that's this tall, so that everyone has the same chance to watch that baseball game. So it really is that difference. It's not equality, it is equity. And there is a very big difference between those two. And we can talk more on that, because I 100% agree with you. It's not about equality, it's about equity and equal access to care.
Yeah. And how, I don't know, you can go a long ways. How do you get everybody equal access to care? That's a complicated.
Yeah. Public health's biggest challenge, but why is our challenge?
Okay. Does anybody have a question for Ms. Ballmer?
I want to say thanks. I don't have a question. I enjoyed the video, and the discussion we're having here is one that I fully understand. I appreciate, because when I saw that, some of those thoughts were going through my mind as well. I suppose when I think of vision screening, which my mom did when I was a kid, and she brought vision screening to Neebish Island, I think that was talking about children having the opportunity to remove a potential barrier. Didn't help them necessarily become perfect in their vision, but they at least, when the parents identified the problem, and now it's going to go with dental. But this was a good conversation, because I understand it's a big apple to be biting here. And anyway.
All right.
Thank you, Jen.
Anything else from the board? All right, thank you. You have in your packets both the hard copy and the electronic copy. You have a written report submitted by Holly Campbell, Dr. Meyerson, Kathleen Jakunovich, Amanda Thompson, Jeremy Fruch, and Ms. Sunmacher. Does anyone from the board have any questions for those directors?
On Dan's report, the second page, the timeline, it says October to January 2022. That was confusing to me.
Oh.
Is that a typo or is that correct?
No, that isn't.
Okay. So it's
Sorry
supposed to
about that.
be 23 or?
Right, right. So October, basically, it should have, really what I should have done is put it October to December. Next one is January 2023.
Okay.
So sorry about that.
No, that's fine.
Mr. Marcus.
Regarding the accreditation program, it was brought up in public comment. The patient wants to ask the question. I was curious, are most of the data points we collect, are they voluntarily or are they required? How is it usually done? Particularly into the heart issues, for example, that was brought up.
So the accreditation program is run through the state. They put out a tool that has indicators that we have to meet for each program. And they're not specific, but one of them in the powers and duties section for health departments is vital statistics. And a lot of that stuff we can get from like the HHS website. We don't necessarily always collect the data because people are going to see we don't necessarily see people, as a healthcare provider, all the, the entire population for a lot of different things. They're going to their primary physician, and that data, some of that data gets collected through those routes. And then they get funneled to the state, and that's the access that we have. And correct me if I'm wrong, Dr. Meyerson, but those are the mechanisms that we have to get certain data. Now, the data that for the clients that we see, we collect all kinds of data that we look at on a daily basis. But like you were talking about the heart conditions, that would be something that is, more between someone in their primary care physician or hospital through ER visit or surgeons and things of that nature. So
wouldn't it fall into the same thing as any other type of reported issues that were reported at a doctor's office at ER? The same information would be available at the state level, what do you think?
Well, and
What makes that so different?
I can't answer that. And maybe Dr. Meyerson has a better take on, exactly how that data is collected and shared, amongst,
Yeah.
as far as what vital statistics.
Well, I think, there are vital statistics that are considered vital, and there's certain things that are collected, cancer diagnoses, certain types of cancers, heart disease, stroke, different things like that are collected. And they're available on this public website where you can look at vital statistics. Not everything. When you go to a doctor and your doctor says you have a rash on your head, you got psoriasis or something, we don't know about that. It could be. And it's not collected. There isn't data. Now, healthcare systems can collect data and they can look at diagnosis codes, but those are not something that, I think sometimes people think that we know everything. We can get on a computer and we can tell you how many people had, leishmaniasis. Well, we can't unless there's certain things that are reportable. So that was a bad example because that is a reportable disease. But how many people, if you have an ingrown toenail, I don't know how many people have ingrown toenails. Maybe there's an epidemic of it. I have no idea. Because it's not reported. Unless if a physician said, you know what, I'm having this unusual occurrence where I'm seeing all these people with this unusual disease, and we like that when doctors notify us of that. If they're noticing something unusual, then we are bound to help look into that, and we can then try to gather more information. But we don't know, we don't collect data on everything, and we don't have access to it. But on the other side, we do, as part of accreditation and part of that mission, is health assessment. So we look at our community health assessment and we try to look at what are the needs of our communities. And that's something, and Jane, I'd let her talk more about it, but we have a very, and I think we've talked about it here, haven't we? Our community health assessment, the My Thrive that hospitals are obligated to do. And so in this partnership, we do a pretty robust job of looking at the needs of our community. Because although the diseases that afflict us aren't that different than the rest of the country or the rest of the state, we do have unique needs in rural northern Michigan. So we try to get that information so that we can address it in the next cycle. And that's a part of the presentation.
So I agree with you to quite an extent. Just 4 years ago, I came from Washington, D.C. from a conference, and I introduced Stepping Up program to our county. It took me almost 2.5 years to get it through to the counties, but eventually now it's in full fledged. It's in action. Northern Michigan, North Country Community Mental Health has been The director there has been moving forward on that. What ended up happening is the data that we never had before was now being collected because we chose to collect it. It was supposedly not available, but sheriffs seem to have that data, but it wasn't until we asked for it that we started getting it. So now I'm at a position where if we have a question, and this is a valid question, why can't we get it? Or can we? I think we should try.
Yeah, it's a good point. And people are collecting data all over the place. And it's just more about tapping into that data or communicating and finding out, where you can get, if I'm collecting one set of data and Charlie's collecting a different set, and just basically being able to communicate and know about each other as far as that goes. So yeah, like Dr. Meyerson said, the community health needs assessment, the bigger picture type stuff, especially specific to Northern Michigan, it helps us identify those areas that we need to look into more. And that's really the whole reason for it. And that is also, part of what we're accredited for, and just making sure that we're doing that.
Oh yeah, this isn't nothing against the accreditation.
Yeah,
Just
yeah.
looking at expanding.
Yep.
What one of the points is, it says we assess population health. Seems like a valid assessment that we should look into and track for the benefit of accreditation or not. It doesn't matter whether it's required or not. I think it's beneficial in general.
Thank you.
Mr. Rubin.
Yeah, this is for Kathleen. She's hiding behind the podium for me, but just my overall observation with kids this age, that the SNAP education, there's two things that are listed: increase consumption of fruits and vegetables and increase physical activity. Well, as a dad, it's my observation that we need to decrease sugar and we need to increase fruits, vegetables, and protein. So I feel like they're missing part of the picture. And I realize the SNAP program is like 194 pages long, but you would think we could get, I feel like the whole American, we know obesity is a problem in youth. That's why we have point number 1 and 2, but we're missing part of the, I just, as a dairyman, I hear all the time about how there's a lot of kids that they don't get cheese, so they don't have good protein. They don't get a yogurt. So I don't know how. I realize you're not in charge of the SNAP. All you're doing is administering it here. But sometimes we need to take points that we know and we see, and we need to pass it back up and say, hey, and these vending machines, a lot of times 3/4 of it isn't even good for our kids, maybe more. Maybe I'd go out and say 90% of it isn't good for them, but that's just me.
I'm with you. I'm not sure if there's a question there or not.
Yeah, and I was just gonna respond that I appreciate.
I'm just ranting.
Yeah,
No.
I appreciate that, and that is actually something that we've talked to our consultant about too, for her to pass up as well, is that this is kind of restrictive and the education that can be provided, and the 194 page SNAP guideline, we have to stay within that. So. But I can definitely take your comment and pass it along again.
And then I got a couple questions for Amanda on the immunization snapshot. So I'm guessing we didn't get anything for a couple years. Is that correct? We didn't get data for, I'm seeing this is a difference between 2019 and 2022. Is that correct?
Yes. So there was some data during 20 and 21, but it was I chose to go back with 2019 because it's more conducive to really the difference, because we had great decreases in 20 and 21 because people weren't out and about, kids weren't getting vaccinated, adults weren't getting vaccinated. And so I really tried to stick with more like what was our baseline and where are we now.
Okay, so take Antrim, the first one, Hep A. the red is in 58%. So that means the percentage went down, correct?
Correct, yeah.
Do we know how much it went down?
I could get that data for you. Most of them were within 2%
Okay.
or less.
Well, that was just my thought. If we're 1 to 2%, I'm not super worried about it. But if we're at 5 or a 10%, now I'm concerned. You know what I mean?
Yeah.
Because years have variations. Kids with this age frame, sometimes their parents move and there's less kids and there's lots of variables. So 1 or 2%, I call that falling within the average. You know what I mean?
Sure.
But if we're getting big swings, then I'm
The biggest swing, honestly, in this entire chart was Antrim County waivers. So they were more in line with the 3 to 4% and have substantially increased.
okay. So explain to me what that waiver means.
So waiver is a school waiver that a kid has to have in order to go to school. So a new entrant, kindergarten, 7th grade are when we measure those. So what that's saying is that our percent of waivers in Antrim County schools has almost doubled in the last few years. So that's concerning because then outbreaks happen. Chickenpox, as an example, you have one kiddo in a classroom that gets chickenpox, and anyone that's unvaccinated has to be quarantined for 21 days. That's just, kind of goes back to the communicable disease. So we worry about outbreaks when your waiver rates are too high.
I think I got it now. I'm a little
Thanks.
slow sometimes.
No, you're good. You're good. Thanks, Jess. I had a quick question on that also, Amanda. It says snapshot rank of 84 Michigan counties. And there are 83 Michigan counties. So is there another entity that's being figured into that? Well, I wondered that, seriously, Josh.
Yeah.
Okay, so that's, okay. Thank you. Okay. I know it seems like a little point, but I wasn't sure.
And then I have a couple questions for Jeremy on the last one.
Okay.
So in the 4 counties, is Antrim County, Milton Township, and Elk Rapids, are they the only two that have required?
Yes.
And Elk Rapids Village, correct?
Correct.
This conversation was brought up at a township meeting that I was at about a month ago. And I'm curious. So it's required in Milton Township if it's been 10 years or more, correct? Since a property has been sold to have a septic inspection?
Was it? I thought it was 5. Dan, do you remember if it was 5 or 10? I don't believe it was 10. I think 10 was. Yeah. Was it too long of a period, right? Oh, it says 10 in this report here. I'd have to look back on it because I took that out of the ordinance.
Okay.
So maybe it says, maybe it is 10 years on there. So I'll double check
I'm not sure, but the township, they were asking some questions and I didn't know the answer.
Mhm.
So if we took Milton Township and we took Elk Rapids Township is probably a bad example since part of it is covered in there, even though it's only 8 sales in 4 years. So are they getting like 2 sales a year? So let's just compare Milton Township and Elk Rapids Township. They're about equal in population.
Mhm.
One has required township wide, one doesn't. One of the gentlemen at the meeting was telling me, he's like, he's in real estate and he's like, I tell people right up, if you're buying a house, I would recommend having the septic field inspected before you buy. So what my question is, Milton Township, quote unquote, everybody gets inspected. Elk Rapids Township, it's optional. Do we have any idea of the townships that are optional? I mean, there's 14 more townships in Antrim County that are optional. Do we know the percentage that get done, or do we have no idea?
I would probably say hardly any other than Milton Township. I'm sure there's some people that do like a third-party home, like a home inspection on them.
But as far as our agency, we do very limited unless we do like a short-term rental situation. Like if they're gonna do a short-term rental, then we would do inspections on them too.
Right, so the health department doesn't do it.
We do it in Milton Township.
In Milton Township.
So I think what the question, what
Oh.
you're asking is, so a realtor may say, just like a home inspection, have a third party, and I think a lot of home inspectors will look at the septic system too. As a third party, not the health department. So with Milton Township, it's the health department that looks at, that does the actual inspection. So we're doing that versus, anywhere else, where it's not.
So do you
Part of an
charge for
ordinance.
that? Do we charge?
Yes, we do.
And do we have a per rate or is it vary
It does not vary. It's the same price.
for
yeah.
everybody? And
Yeah.
what is that, you know?
Oh, boy.
It's 380, I think, somewhere in there.
Right, yeah. And that's looking at the septic and the well.
Septic and well, right?
And that meets all of the health department costs associated with it. I mean, you didn't just pull this number out of the air. You figured out what it takes to have somebody go out there, look at it, observe,
Yes, yeah.
And so we have 53 that were done last year. Is that a half-time person, quarter? I have no idea. Is this take an hour or is this?
I would say, paperwork and everything, probably about 45 minutes in the field and hour and a half in paper, probably 2 hours for each one.
Okay. But it is really variable because if you have a site like a newer house that has good records, you can find everything easy versus a farmhouse that never got a permit ever for anything. Their septic is 60 years old, the well's about the same age. You could spend half a day there trying to figure stuff out. So it is really variable, right?
Well, that's good information because this gentleman at the meeting, I think if I heard him right, he was saying that most of the private ones that he did were charging 500 to 750 roughly.
Really?
And I don't know, different realtors specialize in different kinds of properties. I don't know. But that was.
Maybe we're not charging enough.
I don't know what was
Actually,
involved.
should just advertise.
I don't know what was involved in his inspection, in their
Right.
inspections either. Different inspectors look at different things and do things differently too,
Right. No, I mean, and we're not out, obviously we're not there to make a profit. We're just trying to cover our costs and provide a service. And, I really think time of sale programs are, they work, they're important. And the biggest difference between using health department staff is, we're out there also doing the permits. So it helps with improving our records. We know what we're looking for as far as that goes with soils. We're well-trained, well-educated. So, I mean, that's the plug for, health department staff doing it versus private contractors. But if everybody all of a sudden said, and there's been a lot of action at, state level, or a lot of push to have a statewide, inspection ordinance of some sort. In fact, I think there's a bill in the House right now that is talking about that, or that deals with time of sale inspection. And if we all of a sudden had to do that across the board, across our entire district, I mean, we'd have to hire a bunch of people. I don't know where we would put them. I mean, there's other factors that play into this. I mean, I think it would be really good environmentally speaking and public health speaking. But there are some concerns, especially at a time when it's hard to hire people, and then all of a sudden every health department across the state is having to hire somebody because a statewide mandate comes across to do that. Those are some of the considerations, but I do, like I said, I think in those areas where we do it, like Milton Township,
Any areas that are, have issues with soils or groundwater, I mean, it does benefit areas like that.
and you get systems upgraded.
The third bullet point says the seller meets the requirement for an exemption under section 5. What does that involve,
I believe, so like most, I don't have in front of me, and I don't know if Jeremy, if you know, but a lot of exemptions are like a family to family transfer.
Yeah, I was gonna say that probably in the ordinance here, it's probably for family to family transfer or where it's not actual sale transaction.
Right, or someone's like removing or adding somebody to a deed, but the original owner's still on it, you know, that kind of stuff. Thank you.
Good questions, Mr. Rubin. Thank you.
I was wondering, first of all, Jared, I thought I asked some really good questions about SNAP, and I'm gonna have to do some more reading about this. But the question that I had was, are you gonna eat your second cookie? No.
Hey, Charlie, Shirley's not here. That's all I'm saying.
I'm wrestling you for it.
All right. Mr. Mason?
Yes, for Dan.
Yeah.
So what definition does the health department give in local health department powers and duties? What is your definition of powers for health?
Well, so the powers and duties section is basically it deals with the public health code and specifically what it directs the health departments to do. So every county in the state is required to have a health department, either through, a single county health department or a district health department. And there's certain things that the health department has to do, like investigate disease and have certain programs in place, like mandated programs, like the food service program or on-site wastewater program or water, water supply program, HIV, STD, family immunization program, all those different programs that are mandated by the health department or by the public health code. So it also has to do with, we all know, over the past couple of years, everybody, the public got educated very well about the different powers that the health department has, especially when it comes to outbreaks and epidemics and things of that nature. So it also just basically looks at like our capability of following those, of being able to react if necessary.
Anything else from the board for any of our directors? Okay.
There is one thing on my report at the item 3 there that I do need some action, board action, and it has to do with our annual all staff meeting.
Yeah, go ahead.
So in this, we haven't done this since 2019, but we are planning an annual all staff meeting for Thursday, December 1st, to provide training and team building activities for staff. Like I said, this is the first time since 2019 that we've done this. Previous to that, it was, every December we would have an annual all staff meeting, but to allow participation by the entire staff, closure of the agency is for that day is necessary, and it requires a Board of Health action to be able to do that. And we want to do it well in advance so we can provide proper notice and just be able to, make sure our clients are aware of the closure for that day.
That's Thursday, December 1.
Thursday, December 1. And of course, all the Board of Health members are welcome to join us. Be happy to have you. And yeah, we're going to be doing a lot of staff training that it's just beneficial to have staff all in one place to go over certain things for everybody. And then
is this drawing in all the staff from all 4 different counties
Yes.
to one location?
In one location. Yeah.
Where are you doing?
So we're planning on doing it I'm sorry, I was gonna say Elk Rapids, East Jordan, East Jordan Boathouse, I believe. The name of the facility.
So what you need is board approval to do so.
Correct.
Approximate time.
Approximate time, I think we're looking at,
That's our commissioner meeting. I just want to make sure I knew what time it was because we have our morning meeting.
I'll move that the Board of Health authorize the health officer to conduct an all employee staff meeting involving the closure of offices, facilitate staff participation.
I'll second that.
I think you guys were a tie, so I'm gonna take the motion from Mr. McInnes, and you've already seconded something, so I'm gonna take the second from Mr. Kuntz. Any further discussion?
No, I appreciate Dan asking. I know there's always a few people that they don't see it. They come to the health department building and it's closed, and that's just life. So I appreciate the fact that you're asking and you realize that. I mean, there's probably 90% of us that'll see it posted online or somewhere, but somebody will just be driving by Charlevoix and they'll be like, oh, let's stop in and get whatever, you know.
Right,
so,
right.
Okay. I think we can do a voice vote on this. All in favor, say aye. Aye. Any opposed? Hearing none, I would say your motion is passed. Dan, go ahead.
Thank you.
All right. Moving on, this is the amended agenda portion where we've moved public comment before the closed session. So I will open the public comment once again. Anyone from the public? Ms. Colbita, you want to speak to us? Outstanding. Just state your name, please, and Mr. Pallarito will do the timing again.
Brenda Colbita, Kulbieda, and I would like to donate my time with your permission, sir, to Mary Moore.
Okay.
Thank you.
I'm like the designated hitter in baseball. I don't know very much about that, but all right. So let me just quick comment on the vaccines. There was a quick discussion about waivers, the number of waivers being up for vaccines in the schools. I would say that's a good thing. And I don't think it's a great idea to have clinics pushing the COVID vaccines in the classrooms, which actually are in the schools, which was part of the package. That there apparently are vaccine clinics in some of the schools, which to me, that's a concern, but I assume that everybody's getting parental consent along those lines. In my opinion, these vaccines need to be subjected to a risk-benefit analysis by parents and doctors. Every single one of them needs to be an individual analysis for the individual child. Denmark, for example, I don't know if you guys know this, but Denmark now prohibits kids under 18 from getting the COVID vaccine because they have recognized that there are adverse events that can be associated with the vaccine, and they, and there's hardly any benefit for younger people. They're not harmed by COVID. Brenda told me that Norway is following suit. The same thing is going on in Norway, that kids under 18 are not getting the vax. In fact, are prohibited from getting the vax. Also, you may or may not know this, 95% of US parents of kids 0 to 5 are not vaccinating their children. Also, in the UK, 89% of UK parents are not vaccinating their 5 to 11-year-olds, just so you all are aware. And let me just say this on the subject that I raised of paying attention to what's going on with heart conditions in our 4 counties. Lots of things have been in the news, and I can't even hope to cover it all, but I'll give you a couple of examples. 6 young doctors in Canada died in August or the end of July over a 15-day period, 6 of them. That's very unusual. Usually in Canada, they lose 6 doctors a year, period, not 6 in 14 or 15 days. Lots more doctors have died. You can go look it up and see what you think might be going on there. My son, as I've mentioned before, is a Marine officer. where he is based. One of his peers went out for a jog a few days before he was about to graduate from the basic school. Bless you. And he dropped dead of heart problems. So that's just a personal anecdote for you. The coroner on base wasn't sure what happened. The family had an autopsy done, and yes, his heart was enlarged. So I'm just saying this is an issue we need to pay attention. On March 1 in this community, this board, while I was present, heard from a lady named Pat Freilich, who congratulated this health department because she said that in a local school-based health clinic, one of the health department employees successfully, listen carefully, successfully diagnosed a serious heart condition in a teen wanting to play sports, who then obtained life-saving surgery at the University of Michigan. So I just want to reemphasize, the vaccine should be a personal decision. It's a risk-benefit analysis that has to be made. And really, we need to get to the bottom of what's going on with the myocarditis, pericarditis, and strokes in our young people. Thanks so much for listening.
Thank you, Ms. Moore. Anyone else from the public that wants to address the board? Hearing none, we will close public comment. Next item on our agenda is a request. I believe this is Mr. Thorell's request.
Correct.
To go into closed session pursuant to MCL 15.26H, 268 H, which is our interim health officer's performance appraisal. So ladies and gentlemen, we appreciate all of you attending, but you're all kicked out. Thank you again. And we will allow Jennifer Kenny, I think. Okay. Okay. Thank you. So everyone with the exception